Hello, my name is Ron Oudiz, and this is Simply Speaking Pulmonary Arterial Hypertension. This slide deck is the approaches to complex cases of PAH, integrating evidence-based algorithms. These are my disclosures, and these are our learning objectives. Upon completion of this activity, participants should be better able to identify the key challenges associated with treating patients with PAH, including treatment escalation, side effects, and patient variability in response to treatment. We want you to be able to critically assess current therapeutic options for PAH, considering the efficacy, safety, and long-term outcomes of available treatment options. We want you to be aware of how to design comprehensive multidisciplinary treatment plan for complex patients that integrate pharmacologic as well as non-pharmacologic and supportive care interventions. And then finally, at the end, we're going to be looking at the future and comparing novel and emerging therapies for PAH to traditional treatments, with an emphasis on their role in addressing unmet needs in PAH treatment. This is our agenda. We will start off with the current challenges and describe sort of the landscape of PAH in the United States. We will then proceed to cover 4 cases. This is going to take a while, so be patient. Feel free to forward for areas that you are already familiar with. And then after that, we're going to be talking about those emerging therapies and future directions of PAH, and then a summary for the entire presentation. So what are the current challenges in PAH? If you follow this disease space, you know that PAH is difficult to diagnose, and once you diagnose it, it's often very advanced. And by the time you get there, sometimes the patients are already decompensating. This is a timeline of what we think is going on in the pre-symptomatic stage. And we say this because we don't know how to screen in a rare disease and look at the vessels of a patient with PAH before they become symptomatic, let alone once they are symptomatic, because biopsies are usually not done. So this is more of a conceptual framework of what we think is going on. And the idea here is to understand that probably the earlier you can start to treat these patients, the better off you will be when you first see them in the clinic. And one of the problems in getting these patients early is that the symptoms are non-specific. And so when you see typically a young woman who has shortness of breath, the first or second thing you think of is not usually PAH, unless you're in my clinic, in which case that's always number one. So there's challenges in evaluating dyspnea. There's overlap with comorbidities. Sometimes there's patient denial when you talk about when they finally seek out help. And then I don't want to say physician denial or practitioner denial, but again, it's not necessarily the first thing they think of. Most of these patients, even when they have advanced disease at rest, look normal. And so you have to really have a heightened awareness in trying to screen for these patients. This is a real-world cohort of 2,442 PAH patients. Initially, it was an abstract, but it actually has since been presented at CHEST and then published a year later. And the idea here is that separating these patients from early diagnosis, and we say early in this case, the time from symptom onset until diagnosis, as opposed to delayed diagnosis. And you can see here that the curves split up pretty quickly, and over time, a very big difference of about 40%, 71% survival versus 30% survival in those delayed diagnosis. The French have a registry. They have a system of monitoring every patient in the country. So in this particular study, 1,240 patients were looked at, and they looked at the 4 strata risk of assessment in these patients and the right heart cath on top of that. So if you had patients that were in the intermediate low or the intermediate high risk, and you added one of either the stroke volume index or the mixed venous O2, they call it the SpO2 over there in Europe, and it's favorable, then your survival is pretty good. In the intermediate high risk, it really starts to split apart. If it's favorable, it's 89 versus 76%. And as you see, the high and the low risk, you can see a very big separation, 3-year survival 91 versus 23%. So depending on how you like to stratify, there are lots of registries and there are several publications that look at how to split these patients up. And overall, our conclusion when we look at these numbers is survival is still suboptimal. I'm going to go back one slide and we'll just talk about, even in the patients who are intermediate low risk, 97% 1-year survival. Well, that's telling a 25 or 30-year-old woman who's got newly diagnosed PAH that there's a 3% chance you'll be dead in a year. It's way better with treatment now than it would have been when we first started seeing these patients as treatments were being developed. But nevertheless, it's still suboptimal. And most of these patients aren't low risk. And if they are, many times they progress to a higher level of risk. So these numbers, while they look encouraging, are still problematic. There are ways to differentiate the uh, uh, risk stratification for these patients. As I said, there's different registries, there's different scoring systems. The World Symposium on PAH that met a little over a year ago talked about, they had a task force that covered PAH risk stratification. And they talked about non-invasive risk stratification. They talked about criteria for having significance if you are going to propose a way to risk stratify. It must be prognostic. It must reflect pH and or RV dysfunction severity, and it has to be modifiable treatment interventions. So there are some non-modifiable risk factors, which we'll see later in one of our cases, like CTD, that while they figure in a risk score, they're non-modifiable. And then advancing risk tools as we get better at our data and better at ways to measure severity and integrate those ways into new risk scores, we think we're going to be able to better parse out those at higher risk than we originally thought we had. The access to care is a big challenge for PAH patients globally. The North and South here is divided by the North being US, West Europe, and Japan with strong infrastructure and influence, and the global South like Latin America, Africa, and South Asia, where they face greater economic and political challenge rooted in inequalities. They may not have good diagnostic tools like right heart catheterization even in underserved regions. They may not have access to certain medications. There are still countries that only have access really to one therapy, monotherapy, which is 25 plus years ago when we were doing monotherapy. So the treatment goals really should be get the patient to low risk. And however you want to define that low risk, again, we talk about different ways to assess them. We're getting more towards personalization and trying to look at PAH subtype, what kind of group 1 PAH they have, looking at how severe it is, but also their comorbidities, as well as some patient preferences. And one of our cases has some psychosocial challenges here that we're going to cover later on in the talk. This is the Reveal risk score that you can access online and you can make it interactive. I know some institutions have actually integrated it into their EMR so that it allows for database interrogation and QI and all kinds of things, as well as facilitating instantaneous risk assessment when your patient comes to the clinic. It's one of the most commonly used risk tools, but so are the European risk tools here. And the idea here is that you have different weights to some of the clinical parameters and testing that you can add and create a risk score, a summarized risk score using the most important features here. I will say that while we have RV function here, most of us, at least in the US, use echo more than we do, much more than we do cardiac MR. And in the echo area, you see there's RA area, there's TAPSE SPAP, there's presence of a pericardial effusion, but we don't actually have RV function as typically can be most objectively assessed by cardiac MR. But there's RV strain, there's RV ejection fraction, and fractional area change. And I think part of this is because there is not a lot of data from registries. Doing serial echocardiograms in a registry is very expensive with a core lab. And so what I always try to tell physicians who are seeing these patients is that you have all these risk scores, but you need to further individualize based on what their RV looks like. You need to look at their echo and look at how big the RV and the RA is, what's the septum doing, all those sorts of things are not buried anywhere in these risk tools, but they're extremely important. We'll summarize here some of the timelines of how PAH drug development started and over time where these trials went. They started with monotherapy, as I mentioned before, and we're now in combination therapies and novel therapies that are either used as initial monotherapies as first line or in combination with background therapies. Nevertheless, this represents a progression over time that has put major dents into our treatment armamentarium. And here we have a graphical representation of how these drugs work and how these four targets work. We have the activin signaling pathway with the most recently approved drug sotatercept. We have the prostacyclin pathway, the tried and true arachidonic acid-based therapy using epoprostenol, treprostinil, and in some places iloprost. We have the NO pathway that looks at cyclic GMP as the second messenger and enhancing that signaling pathway. And then we have the endothelin-1 pathway. That's a typo there. It's endothelin, not endothelial. It is endothelial derived, but it's endothelin-1 that is a very potent vasoconstrictor. And endothelin receptor antagonists, or ERAs, are the backbone of treatment for our PAH patients. So the mechanisms we're not going to get dive too deeply in, but suffice it to say that they're all uniquely different mechanisms, all targeting the same idea as to improve the RV afterload and help pulmonary blood flow at rest and during exercise so that cardiac output and oxygen delivery can be maintained to the tissues. This is from a contemporary review of drug therapy, and there's an algorithm in this paper by our colleague Dr. Sahai in the Blue Journal, and it sort of summarizes what the available drugs are and what their route of administration is, and we're going to see references to this paper along the way, looking at those algorithms, the contemporary algorithms throughout. Here is that algorithm that we believe is more US friendly in the sense that it is based on US input at the writing of this article that takes into account most of the things that we are concerned with in our PAH patients. It still divides patients into low, intermediate, high, intermediate, low, and high risk population. And it's pretty straightforward here in saying that initially, with the lower intermediate risk patients, that combination therapy with an ERA and an NO-based drug like a PDE5 inhibitor is given at baseline, but must be reassessed. And I don't do this at 3 months personally. I do this at 6 weeks, giving 2 weeks for the approval of the therapy after I see them in the office, and then another 4 weeks, make sure they're tolerating it, make sure they got it, make sure they're tolerating it, and make sure that they're not getting worse and hopefully getting better by that point. But at least every 3 months, these patients need to be seen in your clinic and follow up. And then reassessing them for risk at each time point when you see them and bumping up their therapy. And here we can see that now this contemporary approach with the integration of the most recent activin signaling inhibitor, sotatercept, you can see that you can either do that or add a non-parenteral prostacyclin, or you can replace your PDE5 with a soluble guanylate cyclase stimulator if the patient is no longer in the low risk category when they were at baseline. And then you can also talk about the activin signaling inhibitor or parenteral prostacyclin if they're intermediate high risk. Moving over to the right side of the algorithm, we're talking about dual oral therapy or managed as high risk, meaning high risk patients get a parenteral prostacyclin plus an ERA plus a PDE5 at the beginning. And what you have then, if the patient remains high risk, is to either add the activin signaling inhibitor and or titrate the parenteral prostacyclin as much as you can, as fast as you can, and as high as you can, and then start talking to the patient if it's applicable about lung transplant. For the very high risk patient, they should have already been on a prostacyclin, and if they haven't been on an ASI, they should have it added and refer for lung transplantation. And you see again follow up every 3 months as a minimum, but in those very sick patients, every 1 to 3 months is about where you want to go with these patients before you lose them. So key points about optimal treatment: combination therapy for almost all the patients. Start with an ERA and a PDE5 inhibitor, both oral for most newly diagnosed patients. But I want to caution that if you're a practitioner and you're only seeing high risk referrals, probably most of your patients aren't going to be just on 2 oral therapies. Parenteral therapy remains crucial for the most severe cases. Early reassessment and escalation of therapy or addition of therapy, augmentation of prostacyclin dose, etc. Maximal therapy now, 4 targets need to be hit for those sick patients. We do need more trials still for better decision-making, for knowing when and where to sequence these new drugs. We don't have a lot of data for an ASI as initial therapy. That's why we're starting with 2 oral therapies, but treatment strategies are emerging. There's potential for upfront triple therapy that includes sotatercept at the beginning. One can argue this is a progressive disease. Why are we treating and waiting for them to get worse? Why not hit them with everything? Well, there's risk benefit there, and there is some equipoise without good data that we need to have for following these patients. So we need head-to-head and strategy studies to further refine those treatment approaches. Failure to achieve low risk status is what we're really monitoring every 3 months for. We want to also, though, look at adverse events. We want to look at whether the patient is actually taking the medicine and able to comply. Can they do their injections? Can they take their pills? Can they do their inhalations? We want to look at drug-drug interactions, especially for those with comorbidities that have non-PAH drugs that might get into the fray. And of course, we're looking for disease worsening and then comorbidities that might actually increase the side effect risk for some of these drugs based on their underlying comorbidities. So next, we're going to move into the 4 cases that we talked about, complex case management in PAH. This first case is a newly diagnosed patient with coexisting connective tissue disease, one of those non-modifying risk factors. She's 50, and her complaint is progressive dyspnea on exertion. She has fatigue, and she has occasional Raynaud's phenomenon. We're going to look at her medical and other history and assessments and talk about her treatment plan. She was diagnosed with scleroderma 5 years ago. She has associated with that GERD. She does have some mild ILD. We can get into that later, how we differentiate between groups 1 and group 3. We can talk about her medications here for her Raynaud's disease, nifedipine. Sometimes patients that are given calcium channel blockers for the purpose of pH are given because they're reading old chapters in old books that say initial calcium channel blocker is where you should go for the treatment. We're not there. We've just talked about the idea of most patients being on at least combination oral therapy up front. She's on omeprazole and mycophenolate for her ILD. She's had no surgeries, really not much in terms of social history. She works a sedentary job. These are her vitals. Her blood pressure is normal. Her heart rate's getting up there, 90s. Her oxygen is 95 on room air. She has sclerodactyly and digital ulcers from her scleroderma. Her pulmonic component of the second heart sound is increased, and she has an RV heave, and her JVP is up. On exam, she has some bibasilar crackles and mild bilateral low extremity edema. Echo shows RV dilatation. RV systolic pressure is estimated at 50 millimeters mercury, and her TAPSE is low at 1.2 centimeters. Her PFTs reflect a mild reduction in FVC. Her DLCO is way out of proportion to that, 40%, and she walks about 400 meters. These are some of the labs from the Practice Point Pathology Lab. You can see that her hemoglobin is 12.8, her bicarb is a little low, TSH is normal, ANA is positive, and her BNP is elevated at 280 with the reference being 100. She's appropriately immediately taken for right heart cath, where you see that her PA pressure mean is 35, her RA pressure is 10, her wedge pressure is 10, her cardiac output's 4. Plugging all that into the formula for PVR, she's at 6 Wood units, which is quite elevated. We use upper limit of normal now as less than 2 Wood units to define PAH. So reminder here that PAH is the broader group of patients that include all groups of 1 through 5 PH. It increases PVR, it increases mortality, the complication of multiple chronic diseases, and can affect up to 10% of the general population, given the fact that it can be across the lines of left-sided heart disease and ILD and CTEPH, et cetera. And we know PAH is a subtype and has particularly worse morbidity and mortality than PH in general, usually. And in particular, when you have CTD, that adds another risk factor. That's why you get an extra point for that non-modifiable risk factor with REVEAL. And then the CTD PAH population, 25% of the cases overall differs from IPAH in that the outcomes are worse. There's more cardiovascular involvement, and there's sometimes need for immunosuppression, particularly with patients who might have lupus. unlike this patient. This is this overall picture of connective tissue disease by one report or by several different reports. Most of them are limited scleroderma. There are some with SLE and mixed connective tissue disease. Of course, there's great variability depending on what center you're at, even geographically, where you're located. There is a recommended screening process for these patients. These are the patients where we actually can actively screen because there are the likelihood of developing PAH in underlying CTD, particularly with scleroderma, is much, much higher than the general population, let's say 10% lifetime risk, whereas idiopathic PAH is a couple per million per year. So you can actually screen these patients and find patients and uncover patients that maybe you'll get them earlier when you do your annual assessment, which is lung function, including DLCO, your echo, and a BNP, and of course a focused exam and a good history. If you find that you meet the thresholds that you see here on the echo and the PFTs and on your exam and your history, then you recommend cardiac catheterization, and you see the definition now that we have for cutoffs for diagnosing these patients. There are delays for scleroderma patients, just like they are for all other PAH patients. The median diagnosis in one study was 2.8 years from time from diagnosis of scleroderma after Raynaud's phenomenon. And in another study between SLE diagnosis and PAH diagnosis, 4.9 years. So got to be careful about this. Here is the same algorithm that we use for our patients, and those patients, like this patient, should be, in this case, looked at as intermediate risk based on the synthesis of all the things that we presented, and started with a combination of ERA and PD5, but you need to follow that patient closely and titrate up the therapy, make sure that she's tolerating it, and regular risk stratification. So the treatment algorithm that we just showed you doesn't differentiate between CTD, PAH, but treatment choices can be more complex because of their comorbidities, the concurrent immunosuppressant use. In fact, in some patients, their disfigurement and their inability to draw up medications from a syringe or even open a bottle of medications can severely limit these patients. And so you really got to make sure that even visiting the home when the specialty nurses take a look at what's going on, make recommendations as to how your patient is going to float or sink. So PAH is a serious complication for patients with CTD. It's the leading cause of death in scleroderma and lupus. It varies by region. There's more scleroderma in the West, while more lupus and MCTD dominate in Asia. Routine screening we already talked about annually, and multidisciplinary co-management improves outcomes in CTD-PAH. So hopefully you have established relationships with your local rheumatologists, not only to help them understand how to screen, but also help them understand how to pick up early disease or progressing disease once they've been diagnosed. The next case is much more complex. This is refractory right heart failure with multi-organ dysfunction. And this is really for people that are practicing and taking care of patients in the acute care setting, particularly in the ICU. This is a 60-year-old man whose chief complaint is severe fatigue and worsening leg edema with abdominal distension. He was diagnosed with IPAH 8 years ago and placed on treatment. He now has CKD3, he has liver congestion, he has AFib, he's on oral therapy plus diuretics, and digoxin was started for RV support. And he was hospitalized because he came in heart failure, right heart failure. He had a pacemaker placed for AFib, but no other surgeries. He used to smoke, no longer does. He's got a sedentary lifestyle, is retired, and he has a history of early heart disease in his father, but no family history of PAH. His blood pressure is already 90/60, and his heart rate's over 100, 110 here, and his JVP is elevated. He has a loud P2, he has an S3 gallop, lungs are clear, and he has severe pitting edema, and he also has ascites. So here's the cycle of RV failure in PAH. You have systolic and diastolic dysfunction, you have decreased coronary perfusion, the RV becomes more ischemic, the transmural oxygen demand is going up, and you have then altered microRNA, expression, altered metabolism, mitochondrial dysfunction, and all sort of spits off into these ideas that drugs, infections, and inflammation and hormonal influence can affect this. Genetic predisposition might affect this. Pulmonary vascular remodeling occurs, and then the cycle continues. In this patient, there's severe RV dysfunction. Again, I always make sure that I look at the echo myself. Don't look at a report. Go look at the story that the echo tells, the picture that the video tells. Patient has moderate TR, no joint deformities, rashes, clubbing, or cyanosis. Didn't miss anything in terms of underlying comorbidities there. His ALT and AST are elevated, and his bilirubin is starting to go up, probably from passive liver congestion due to chronic right heart failure and only being on dual oral therapy. And he's got CKD, his GFR is 40. The lab shows a bicarb of 20, a TSH is normal, maybe a little bit higher than normal. ANA is negative, and the BNP is up to 1200 in this case. Here's his cath. His PA pressure is 50, and his PVR is 13.5 Wood units, and his RA pressure is elevated at 20. Prognostic, and his cardiac output's low at 3.4. So prognostically, just this hemodynamic picture alone is huge. And you throw that on top of the rapid decompensation, the low blood pressure, the high heart rate, the volume overload, things are not good when you put that all together for this patient. So you've diagnosed severe PAH with severe volume overload, renal dysfunction, and he's in cardiogenic shock. So here are the principles in management of right heart failure. Treat the triggers, look at those things like infection, arrhythmias, comorbidities, etc. Optimize the fluid balance, make sure you treat the hypervolemia carefully, particularly because kidney function is impaired. I often find that when these patients come in, their RA pressure is 20, we get it down to 15 overnight with diuretics and inotropic support. Their heart rate goes down, their creatinine goes down, GFR goes up, and you're getting them out of the heart failure syndrome, vicious cycle. Reducing RV afterload is sometimes a part of that, where you might need IV prostanoids as well, or if you have availability, inhaled nitric oxide. Optimize the cardiac output with inotropes. I mentioned I like to use milrinone. Some people like to use dobutamine. I find less problem with arrhythmias, especially when they're tachycardic, using milrinone. And vasopressors, if the blood pressure is low and they're not perfusing, I prefer vasopressin because it doesn't have a spillover effect into the PA. If you constrict the PA and you constrict the aorta and you improve systemic blood pressure, but you also increase PA pressure, you're not doing the RV any favors. There is talk here about ECMO, preferably awake, bridge to recovery, bridge to transplant. If there's no realistic recovery prospect or lung transplantation is not an option, palliative therapy idea here is goals of care, et cetera, and the best supportive care you can. You can get them out of the hospital sometimes, even if they're no prospect of long-term fantastic recovery that you would hope for. But sometimes you can keep these patients going, particularly with the quadruple treatment armamentarium that we talked about up in the first section of this talk. Management of right heart failure, that includes many things here, which I don't want to spend too much time going over every little box. But the idea is, as we said before, that you're looking at afterload, you're looking at coexisting things like arrhythmias, and you're looking at preload, volume, and kidney function, and all those important things in a very sick ICU patient, not for the faint of heart. Here again, this patient is getting ICU admission, inotropic support, fluid optimization, consideration for lung transplant if he is willing and if he is a candidate, and then looking at the need for mechanical support. Monitoring these patients is pretty standard, I think, when you talk about the ICU. The echo is important. We don't do daily echoes in these patients, but if there's been a clinical change and you're concerned about things not going the way you want, reevaluate that RV. Reevaluate the patient may have pericardial effusion. Look at what happens to the tricuspid valve. Sometimes these patients with very high pressures can actually flail their tricuspid leaflets. And that's an acute decompensation where you get severe TR to wide open TR. And then you have to have that central line access for monitoring continuously. I won't spend too much time looking at RVADs and mechanical circulatory support. These are things that are very dependent on the local expertise and the availability in the institution. Okay, now let's look at the use of prostanoids and activin signaling inhibitors. And this is coming up appropriately when we talk about the very sick patients, because the standard of care in the ICU, as we said, is doing all the things that we said, and including parenteral prostacyclin, preferably IV epoprostenol. It can be dosed up and down quickly, and you can have a rapid onset and rapid offset if you go too far. Looking at IV EPO or IV treprostinil, the gold standards for severe PAH and high-risk patients, the prostacyclin pathway we know improves pulmonary blood flow, decreases RV afterload, but it requires continuous IV infusion. Your nursing team and the hospital team needs to understand how the pumps work and what to look for side effects and what to do with line interruption, et cetera. Sotatercept is considered next generation therapy. It targets BMPR signaling, activin signaling inhibitor. The STELLAR trial showed a 26% reduction in mean pressure, a magnitude of effect previously only seen with triple combination therapy that included IV prostacyclins. And even in patients that were in these trials on maximum vasodilator therapy, on triple therapy, there was still a huge dent into decreasing PVR. So sotatercept can also improve functional capacity and reduce PVR, as we just said. IV prostacyclins improve cardiac output, but sotatercept actually doesn't change cardiac output. We're not exactly sure why. And in the pulsar extension phase of that study, the delayed start and early start sotatercept groups showed similar to hemodynamic improvements at 18 to 24 months. So where are we going with all this? The idea here is that these two drugs really haven't been compared head to head. Sotatercept is certainly less burdensome. It has different side effects than IV epoprostenol, but it is a novel mechanism beyond vasodilatation that works probably as a disease modifier for patients with PAH. And it could be that the combination of sotatercept and prostacyclins in the acutely ill patients could be the next frontier for severe PAH. There's no data. Long-term effects of therapy choice and sequencing on survival and RV function remain areas for further study. If we can get that data and can design a trial that will be feasible and informative, then I see that we're going to have a major shift in the way we treat acutely these patients, as in the patient in this case. So important points to learn about these acutely decompensating RV failure patients is it's the RV dysfunction that drives the progression and worsen outcome caused by the afterload in the pulmonary circulation, and reduced distensibility is a major underlying mechanism in there. Early RV dysfunction affects exercise capacity and transplant-free survival. So management priorities would be to reduce preload, like we talked about, enhance contractility, prevent ischemia, and lower afterload using targeted PAH therapy. ICU strategies, including ECMO as a bridge to transplant, is used, but not recommended for end stage without transplant eligibility. If there's no place to go, no destination, not recommended. Lung transplantation itself probably deserves its own separate 1-hour lecture. Early referral is key. The transplant team needs to see these patients as soon as you're thinking about the possibility, so that they can have enough time to screen the patient and get them presented to the board so they can determine eligibility and optimize their medical therapy. Perioperative ECMO improves outcomes with more than 90% survival in some centers in one study. Long-term strategies will continue to evolve as the roles of newer targeted therapies become clearer, and hopefully as the outcomes and as the transplant rejection armamentarium evolves over time as well. The third case in section 2 of our cases is a meth-associated patient with PAH that has severe PAH and psychosocial comorbidities. 45-year-old male who complains of dyspnea, chest pain, and anxiety. He has 15-year history of meth use, and the last used 3 months ago. Anxiety, depression, bipolar. He has hypertension and Hep C. He's on some medications for depression, amlodipine for hypertension, and benzodiazepines for anxiety. Long-term meth use, as we said, and bipolar disorder. He also has unstable housing, difficulty with taking his medicines, no family history. This is an overview of the proposed mechanism of how meth does what it does. And I'm not going to spend that much time into all the different mechanisms, but as you can see here, it's not just one thing. It's all kinds of spillover side effects that has to do with serotonin, mitochondrial function, endothelin, and endothelial function that leads to vasoconstriction, proliferation, and vascular remodeling. And also, there's a component of cardiomyopathy that we'll talk about in a second. The demographics of meth use seem to be dependent on where you are, and we seem to see more on the West Coast than we see in terms of drug abuse in PAH patients than we see in the Northeast, where there seem to be more narcotics and fentanyl type abuse. But nevertheless, it's pretty common. And one could say that there is at least countrywide epidemic of meth use as well as meth PH and meth cardiomyopathy. This is a paper back from 2018 that looked at the survival among different groups who have either meth PAH or meth cardiomyopathy compared with control on the left. They just really removed the control on the right to show you that they're bad from a prognostic standpoint of 10 years, 40% 40% survival. And both are uniquely different in terms of pathologically. One is the APAH, the RV failure component, and the other is the LV failure component from the meth cardiomyopathy, but both are bad. Men or women over time, both are seeing an increase in the numbers of deaths from methamphetamine use. So there's that epidemic again that seems to be getting worse. And then comparing meth APAH to IPH, it says here from these studies referenced below that IPH is older than meth PH. I think that's highly dependent on what your meth population is and what your IPH population is. IPH is typically a disease of young women. If you throw in APAH, where the CTD represents the biggest component, then it's still female predominant, but the age moves up into the 45 to 65 range. Nevertheless, with meth PH, there still seems to be some female predominance. Maybe you'll see in the slide in a second, maybe that's hormonal, maybe that's the estrogen hypothesis. But patients seem to do worse with meth PH, and particularly if they're still using meth. When we started treating patients with meth PH, if they came back into the clinic, and even if they were taking their medicines, and usually back then we were just doing monotherapy, but continued to use meth, those patients usually didn't survive beyond a year. Now we're seeing them many years, very sick, but surviving probably because of initial combination therapy and because of the effectiveness of our therapies. This patient's blood pressure is normal, heart rate's a little high, it's restless, anxious, tremulous, there's an RV heave, the P2 is increased, nothing on lung exam. There's RVH and an RV pressure estimate of 65 millimeters of mercury. Psychiatric evaluation reveals depression and active anxiety symptoms, and he is positive for methamphetamine, even though he said the last use was 3 months ago. These are his labs. His BNP is 450, indicating definitely RV failure syndrome. His RA pressure, in fact, is a little elevated at 12. His mean pressure is 50, and his PVR is 10. Not subtle here. That's a very high PVR. The treatment approach here is really not much different from the treatment armamentarium of the PH therapies basis, combination therapy for low intermediate risk, and then prostacyclin infusions, et cetera, for the high risk. But there's challenges here with these patients because most of us don't want to consider putting a central line in a patient who's got anxiety issues, who's actively using drugs, and may have also psychosocial issues with accessing medications and using pumps and monitoring lines for infection and making sure those lines don't get pulled out. So there are obviously some challenges that we have, psychosocial challenges for these patients. A patient can hopefully be compliant enough to take their initial double oral therapy up front. Referral to an addiction specialist makes sense. We call it the MAT team here. Cognitive behavioral therapy, psychiatric follow-up, and then social support. What kinds of things we can do? Talk about abstinence. We can talk about addiction medicine specialists, referral to social workers, drug testing programs. What about lung transplantation? Well, it's not an absolute contraindication for a patient that's abstinent. Documenting abstinence for an extended period is extremely important. I know some of our local transplant centers will not transplant a patient within a year of last cigarette use. So not just drug use here, we're talking about just cigarette use. So it's really important to really get a handle on how you're going to you're going to be able to support these patients. And in most cases, for us, transplant isn't an option because of the ongoing meth use. It's a significant global issue, affects men and women, definite risk for PAH development. Meth patients tend to be younger, but they present with worse disease, more advanced and worse prognosis. There is that estrogen paradox idea that may be responsible for why there is a slight female predominance. With rising meth use in the US over time, understanding the pathophysiology is critical for prevention and targeted treatment development, for which now we have none. It's all generic. Okay, the last case I'm not going to spend too much time in. It's a pediatric case. I'm not a pediatric specialist, and children are not small adults. But if you're interested in learning about this, you'll have the slides to look at. For this case, 7-year-old, fatigue, poor weight gain, and worsening shortness of breath. I'm told that children oftentimes look completely normal and can run around for a while until they suddenly pass out. They don't know when to stop. They may not have the warning signs that adults have. This particular patient had congenital heart disease, a repaired VSD at age 3. He had failure to thrive, mild scoliosis. He's on dual oral therapy and nutritional supplements. No known family history. Here are his vitals. He's tachycardic. Growth chart is below the 3rd percentile. He has some evidence of RV failure on exam. He can only walk 150 meters, which is pretty low for his age. It's a little difficult for a 7-year-old to know exactly what normal is. I think 7 or 8 is around the cutoff where you can start to reliably do 6-minute walk tests for the purposes of prognosis and monitoring these patients. So it can be a challenge in how otherwise you would monitor them. BNP is elevated here at 600. Here's the cath, the 6 Wood units is elevated. RA pressure is a little bit high. There is a separate diagnostic algorithm that's been proposed, and this comes from a couple of recent publications that's fairly similar to what we do for the adult population, but it takes into account some maybe different comorbidities or different underlying contributors to PAH here. Cath remains the gold standard, but it's very risky, especially in neonates and infants who are small, critically ill patients. They don't do very well, different than in the adults, where we really have a good handle around how to manage these patients in the cath lab and or the ICU. But for pediatrics, it can be very, very challenging. And so this is not a case where you would want to have a local cath lab do the cath. You would want to have it at a high volume center that specializes in cathing these patients and taking care of that pediatric population. There's also a different classification of congenital heart disease associated PAH, looking at the different groups of congenital types of congenital defects. But then there's also the risks that are very, very similar, looking at the, if you will, the green light on the left and the red light on the right, without really the intermediate in this particular depiction of risk status. Genetics and CT imaging, sleep studies, PFTs are recommended for these patients. Continual reassessment, of course, like we do for adults. Growth and nutrition support has obviously been initiated and important for these patients, as well as the psychosocial support for the patient's family and caregivers. And then a long-term plan for these kids often is lung transplant if they're candidates. Reverse pot shunts may also be considered. That really should be left up to the team with the expertise in how to do those surgeries. This is a proposed from 2024 European Respiratory Journal, a proposed treatment algorithm looking at vasoreactivity testing and stratifying low risk versus high risk, and then separating into those who have other cardiopulmonary conditions. So these patients often are not just born with one defect, but they have a bunch of things going on. And so there is actually here a consideration for a role for initial monotherapy for these patients who have developmental lung disorders. Again, this lack of data that we have for these children versus adults that are easily recruited into studies. Proposed treatment algorithm for the congenital diaphragmatic hernia is shown here. I'm not going to spend too much time there. Congenital heart disease may persist after repair or develop insidiously. That means that we see patients, of course, who develop Eisenmenger syndrome, but if you catch it early and repair the hole, close the hole, there may be residual PAH. That patient is now converted to a regular PAH patient without a pop-off valve. So you have to screen these patients very carefully and very closely. So just some learning points for this congenital heart disease group. The CHD, as we just said, may persist after repair. You need a multidisciplinary approach, collaboration among pediatric cardiology, pulmonologists, PH specialists, if those two up front aren't already treating PAH. Surgery and timing, extremely important. You have a good surgeon and a good team that understands when to intervene and how to intervene. There's a post-op PAH crisis management. Residual PAH post-repair patients are at risk of acute PAH crises and RV decompensation. You have to be careful with invasive monitoring and rescue therapies. Individualized, obviously, every patient with congenital heart disease can be so uniquely different, and the makeup of what their underlying risk factors are can be very, very variable. Even after surgical repair, patients require lifelong surveillance to monitor for progression and need for therapy escalation. Okay, let's talk briefly then. Hopefully, we're just getting a little past 1 hour here. We can get through this in the next few minutes. This is a microcosm, if you will, of what is perceived to be a large cauldron of targets and mediators that contribute to the development of pulmonary vascular disease. Some of the common ones we're aware of include BMP signaling, activin signaling, as PDGF as well, inflammatory DNA damage. We talked about things like the growth factors and proliferation, but also off-target things, PPAR gamma. There's a lot going on here, and these are what form the basis for future therapies and testing of future therapies. But it's still not really well understood in how all these things interact in the individual patient. Some of the key clinical trials that most of us are familiar with that are working on PAH drug development include the ASIs, the Hyperion, Zenith, Soteria, and Cadence trials. There's also seralutinib that's being looked at with the primary outcome of change in 6-minute walk. There's the advanced study looking at ralinepag as primary outcome and time to clinical worsening. There's inhaled vardenafil study, and there's a long-acting treprostinil study looking at PH-ILD with a long-term safety and tolerability primary outcome and potential expansion into the PAH world, depending on how that looks. Nanoparticle-based drug delivery is in there. Inhalation is usually the method of administration. Innovative genetic therapies, microRNAs, correcting genetic abnormalities. I think we're going to talk about epigenetic mechanisms here in this next slide, where we're not talking about changing base pairs and altering the DNA, but altering the function of DNA and RNA and how those can lead to a potential therapy approach. So disease modification with these emerging therapies like sotatercept and soon to be reported seralutinib represent a shift from symptom management to potentially disease modification by targeting pulmonary arterial remodeling. Disease modification, depending on how you define it, implies that you're changing the ultrastructure of the disease permanently and reversing it in a way that gives you some change in the ultrastructure, presumably of either the right ventricle or the pulmonary vasculature or both. But it is a very difficult thing to actually prove. Novel therapies may help in combining these agents with existing therapies like our ERAs, PD5s, and prostacyclins, potentially further reducing the burden of long-term PAH. There's always concern with these therapies, though, of side effects and off-target effects, especially as we get into more and more combinations of therapies. Some therapies aim to achieve low-risk profiles, study designs, if you will, that focus on achieving low risk rather than necessarily just dropping PVR or just increasing 6-minute walk tests. And of course, quality of life is important for our patients. And from the patient perspective, quality of life is a big focus. So there's personalized medicine with focus on biomarkers individually tailored for the individual patient. There's platform trials with innovative trial designs, the testing an array of multiple therapies simultaneously, improving the efficiency of the trial itself, remote monitoring, maybe with wearables, implantables, and maybe AI that's going to help us with better trial designs, better follow-up for these patients, and overall better outcome. What about genetics and genomics? We talked about sometimes the mutations that are there and maybe fixing those mutations, but maybe just epigenetics is a better lower bar target for these patients. Genomic studies have uncovered genetic variations in pulmonary vascular homeostasis, in particular with the ASIs, and that was the basis for how the BMPR signaling was targeted as a therapy because of the BMPR signaling abnormalities that we know exist, particularly in the heritable PAH patients. But interestingly, the non-heritable PAH patients still enjoy benefit, can enjoy benefit from an ASI, even though they didn't necessarily have a family history of BMPR signaling abnormalities. The implications here for future therapies from precision medicine are great. We're seeing it across the board worldwide for all kinds of diseases, and we're not there yet with PAH, but the implications are quite great. So to summarize, diverse PAH treatments are now available, but the disease can be rapidly progressive, slip right through your fingers, and require early re-intervention. Individualized treatment plans should address PAH severity as well as comorbidities. Achieving a low-risk status is the primary goal, with combination therapy as a key strategy upfront and adding more therapies on top rather than replacing therapies. Regular monitoring, as we said before, initially I like to do 6 weeks, at least every 3 months on a regular basis. Multidisciplinary co-management approach helps reduce care disparities and improve outcomes. Aligning PAH treatments with patient-centered goals ensures better care access, support, and advocacy worldwide. Just a reminder to return your activity pages for this session. Click on Claim Credit, complete the brief post-test, and upon successful completion of the post-test, you will get your certificate mailed to you. Here is the link for Practice Point CME to review other presentations of interest and receive additional accredited credit. Thank you.